for the invitations. I'm going to speak about complication of aortic neck dilatation after EVAR, prognosis and management. So what causes aortic neck dilatation? Usually it happens in both in open and endovascular repair, and usually due to the continuous aneurysmal degradation of the aorta. But EVAR also causes more force on the aorta, which can cause also more neck dilatation because of the self-expanding devices and oversizing. So what are the risk factors for neck dilatation after EVAR? We have some anatomical factors like neck morphology, conical angulation, thrombosis, and size of the neck at the baseline. The device type, are we using device with a suprarenal versus infrarenal fixation? Are we using self-expandable versus balloon expandable stent at the fixation area? And how much we oversizing? This is a very nice paper published recently about systemic review of the proximal neck dilatation after endovascular repair of abdominal aortic aneurysm. Is a meta-analysis of 26 papers between 1998 and 2015. They look at around like 10,000 patients, and they found that neck dilatation after EVAR happened about almost 25% of the patient. So what they conclude that neck dilatation affect considerable number of the patient after EVAR, and was rated to the worst clinical outcome as indicated in increased rate of type 1 endoleak, migration, and reintervention. But really the landmark paper is come from Dr. Bishara, where he looked at the effect of stent graft active fixation and oversizing on aortic neck dilatation after EVAR. It's a single center study over 10 years. He has about 432 patients, and he did yearly CAT scan for 4 years. And he measures the largest aortic diameter 1 centimeter above and 1 centimeter below the renal artery, and he calculates the millimeter difference in the supra and infrarenal aortic neck from each CAT scan and compared to the pre-op CT scan. And he used a different kind of devices. He used Gore, Cook, Medtronic, and Endologic, and he used also different devices with a different fixation. About 50% he used a device with an infrarenal active fixation, 25% with a suprarenal and active fixation, and 26% only with the suprarenal without active fixation. Also, he used different type of oversizing, less than 10%, 10 to 15, and more than 15, and he'll compare all this kind of a group. So what he found that for suprarenal aortic diameter changes over how much we oversize, he noticed that if we oversize more than 15%, this is the group who has the highest change in the suprarenal aorta diameter after EVAR. For the infrarenal aorta, the same. If we oversize more than 10 to 15%, this group also has a highest number of aortic neck dilatation after EVAR. And in both, the difference was statistically significant. Then he looked at the fixation type for suprarenal aorta diameter. He noticed that if you use a device with a suprarenal active fixation, they have a highest number of neck dilatation than other kind of fixation. And the same for infrarenal aortic diameter. Also, if we use a device with a suprarenal active fixation, then we have a highest number of neck dilatation after EVAR. Then he looks at the graft size, and he noticed that if you use a graft size more than 28, then this will increase your incidence of neck dilatation after EVAR. So what he concluded after 4 years, that the group with the suprarenal active fixation devices showed the largest change in the aortic diameter over time in comparison to the other two groups, and this was statistically significant. Also, he noticed that if you have less than 10% endograft oversizing, this will significantly decrease incidence of neck dilatation comparing with the other group, and this is again was statistically significant. Another paper, again published recently, look at the long-term evaluation of proximal aortic neck dilatation after EVAR. It is a prospective cohort study of 157 patients. They use an EVAR with a self-expanding stent for proximal fixation. They ran between 2013 and 2017 over 5 years and did yearly CAT scan. And we conclude that they noticed that the juxtarenal aortic dilate about 1.8 millimeter in 2 years and 3.9 millimeter at 5 years. And they came with a risk factor very similar to Bishara paper, which is oversizing neck diameter more 28 and sac size in index operation as a risk factor for neck dilatation after EVAR. Another, again, new paper look at the risk factor and adverse event related to supra and infrarenal renal aortic dilatation after EVAR. This is a 12-month study. It's a cohort study, 150 patients. And again, they come up with the same risk factor. Neck diameter more than 29 millimeter, suprarenal fixation, and oversizing more than 20%, all of them cause dilatation of the neck after 12 months. So you can see all the paper, they came with the same conclusions. So what the ideal stent? Do we have an ideal stent to prevent that? Unfortunately, we don't have it, but we have some solution. One of the solutions to use the Ovation Prime device, which is the first FDA-approved device, which they don't use the self-expandable stent for fixation, but they use a two-ring with a polymer, fill up with a polymer. And the more this ring being filled up with a polymer, then there's no more force, outward forces on the aortic neck, and this could prevent neck dilatation in the futures. The other thing to use the balloon expandable technology, which is not available until now, or to use uncomfortable technology, again, it's not available now. The other things to use endo anchors. Why is that? Because if you look at that, when the neck dilated, you can see how the graft separate from the aortic wall and cause migration. But if you have an endo anchors, even if the neck dilated with the time, you can see how the graft still fixed to the aorta. So this could be one of the solutions to be used as prophylactic in the futures. So how we manage neck dilatation? We have different way. We can just put a cuff with endo anchors, or sometimes use a chimney, or BVAR, FEVAR, or coning with onyx, or debranching, or sometimes we have to convert to the open repair. So how we decide that? We measure the distance between the EVAR and the renal artery. If we have like a neck length at least 4 millimeter and sealing zone 10 millimeter, this would be a good case to put just a cuff and put an endo anchor. But to put an endo anchor, the most important that the distance between the aortic wall and the EVAR should be less than 2 millimeter. And if you have any thrombus, again, should be less than 2 millimeter and should not have any porcelain aorta, because otherwise the endo anchor will not penetrate the aortic wall. This is one of patient. He came later on with, because the neck dilatation, sees the graft migrated downward, and we have type 1 endo leak, and we treated with just put a cuff and endo anchors, and we get a good result. But if the distance between EVAR and the renal artery is very short, like 5 millimeter, then endo anchor will not work. Then you have to go to suprarenal fixation, and then you have to go either with a CHIVAR or to have a BVAR. How we decide that? Of course, BVAR is FEVAR. Is a custom-made, is very solid technology. We have a very good data to support it, and this is always our first choice. But the problem with the FEVAR is that it's need a more accurate deployment. Technically, sorry. No, we can go back. Here. The problem with FEVAR, it need more technical skills. It takes a long time to order it, and it's more expensive. But again, it's solid technology, and it will be our first choice, whereas CHIVAR is good for emergency, off the shelf, and cheaper. But the problem, of course, with the CHIVAR is the less wall opposition, and always we have a gutter leak, which always could be a problem. The other thing, you can use an onyx if the dilatation is not too much. Like this patient, he came with, because you can see the EVAR exactly at the level of the renal, so we don't have a migration, but we have type 1 endo leak because of the neck dilatation. So this one we treated with the onyx there, fill up with the onyx, then with some endo anchors to be sure that we get a good seal. And this is a follow-up. You can see we get a good seal and no endo leak. The last thing is that you can do debranch. If you decide to go with an open repair, this is other like alternative way before you go all the way to the open repair. You can use debranching if you don't have access to the FEVAR technology or chimney. It's less complicated than open and less neurological results. This is one patient came to us again after open repair with dilated suprarenal aorta, like type 5 thoracoabdominal aortic aneurysm. At that time, we didn't have access to the FEVAR because this would be a good result, good case for FEVAR. So we decided to go with the debranching. We branched his renal, SMA, and celiac, and then we put TEVAR, and we had good result with a CT follow-up. So conclusion, EVAR with self-expandable stent and endograft oversizing create a radial force that led to the aortic neck dilatation, but this force decelerated after first year after EVAR placement. Baseline aortic neck diameter more than 28 and suprarenal stent endograft are associated with the increased risk of aortic neck dilatations. END and EVAR lead to the worst clinical outcome as indicated by increased type 1 endoleak migration and reinterventions, and proper placement of the graft just below the renal is very important, and as well using balloon expandable stent can reduce the risk of neck dilatation and type 1 endoleak in the future. And finally, using polymer ring instead of self-expandable stent for proximal fixation as an ovation prime device may decrease the incidence of aortic neck dilatation. Thank you very much.